Awesome. Thank you so much for inviting me to discuss one of my passions. This topic is something I've explored a lot and spent a lot of personal time on. And I'm from Chattanooga, Tennessee, and we're going to be talking about a true transosseous hybrid rotator cuff repair. And I have a relevant disclosure. I'm the founder of a company that makes a reusable transosseous tunneling device. When we talk about our ideal repairs, this is straight from Christian Gerber in the 80s. We want initial fixation strength to resist ultimate and cyclic failure. We want to prevent or reduce gap formation and adequately assess shear forces. But we also want to restore the footprint, which I think we're doing here. This is a transosseous repair. We want to be able to have multiple fixation points to reduce these deformities, the bird beaks and the dog ears, and have anatomy that's restored. And you need multiple fixation points to do that in addition to load share. We also, I think, need to be mindful of bone voids and surface area for healing and the biology that imparts to the healing of the repair. There's been an anchor-induced failure mode recently caused by TOE type repairs, which causes a stress riser here medially and leads itself to an anchor specific failure mode, which is catastrophic, called the type 2 failure. I think we need to be aware of that. And that creates a revision scenario that's quite difficult in some cases. And we want to have good results. And of course, but I'd like to introduce perhaps some new ideals. I think we should be looking at improved healing responses and the biological healing that can be quantified on MRI and the healing characteristics that we get. We want to be able to utilize our patches and the biology that's probably the key to repair, but under the surgical cost ceiling, because we can't just keep adding in these things. They're too expensive, and it's just not practical in most of our systems. We'd like to have improved vascularity, which has been shown with transosseous repairs to be excellent. We also want to match the modulus, not exceed the modulus, and we want to restore the footprint. And we've known for a long time that transosseous repairs are the best way to recapitulate the footprint. And through this transosseous cerclage effect, we also want to be mindful of cost. We all have to have this optimization equation of time versus cost versus quality and implants and surface area and all these things. And every cuff repair is a problem that we have to optimize. This concept of load sharing, I think, is very important. So multiple fixation points instead of pressure spikes is going to be very important to redistribute the load mechanically. I started into this topic with an interest in value as defined by the Harvard Business School as outcome over cost per episode. Many of you are in single payer systems already, and this has been a problem in the United States. We've managed to hide the cost problem through a very complicated third-party payer system, but we've definitely had technological convergence and commoditization of implants. You know, an anchor is an anchor; they're commodities, and something that can provide a non-inferior, it doesn't even have to be superior, just a non-inferior outcome and cost effectiveness offers superior value. And we're in a prime zone for that in shoulder. E.A. Codman, the person who repaired the first rotator cuff, was measuring this, you know, even back in his early days, and talking about this got him actually kicked out of Mass General. So this has been around for a while. Randelli and Castagna out of Italy introduced me to this rotator cuff repair cycle. And we have transosseous. So there's a logical progression that progresses from transosseous open back to arthroscopic. This is the transosseous cerclage effect. It's the best way to restore the footprint. We came to mini open with anchors, doing the same thing, but adding a lot of hardware cost. And then when we came to the arthroscopic repair, we went to single row anchors. And this is where we had a lot of problems with outcomes and an inferior repair. And then we added extra anchors to recapitulate the transosseous repair, adding a lot of cost and adding a new failure mode as well. And where I'm trying to work,
I can learn to understand you much better.
think we may need to mute.
Yeah, a few more.
Dr. Kovacs, can you just mute Dr. Kovacs? Would you please? Yeah, thank you.
So, we're at the transosseous equivalent down here in the bottom left. And what I've worked on is this hybrid technique to try to step surgeons who are used to anchors into adopting transosseous techniques, which have many advantages, and to go fully transosseous arthroscopically again, and come back to this same methodology with less cost and a lot of clinical and biological advantages. Initially, when we went to arthroscopic techniques with single row especially, they were disastrous failures in terms of outcomes. This has been shown with 90% or 80% failure here with these studies on the left, and why they failed, whether you're a biologist or more of a biomechanics maven like Burkhardt or like Snyder here, a biologic approach, tension and biology on the left, is up for debate. But the solution that came to the fore offered by the industry was a biomechanical solution with the transosseous equivalent. We've just heard that discussed. And these very smart authors came up with this, and this was a natural evolution, and they were comparing this to double row, not transosseous, fully transosseous. It was double row anchors. And they say in their paper that they were exactly trying to recreate the traditional open transosseous cerclage effect. And compared to double row, these anchors created more mean pressure over the footprint in the lab, and they had a higher load to failure with no more gap formation. They had 400 newtons or so versus 300 newtons or so. And in their paper, they state that 302 newtons is the theoretical force which we wish to achieve. That's the contraction of the supraspinatus. So that's really all you need for healing. And the advantages that they list in their paper here talk about lower profile knots than double row, not relying on the torn tendon edge for fixation, reducing surgical time, placing anchors, eliminating some of the anchors from the healing zone, load sharing, interconnecting fixation points, lateral fixation, which is orthogonal to the force vector. And I realized that all of these could be achieved with transosseous approaches, actually. And so this is where we have stepped now into the hybrid technique, which I'm about to show you. We have known that the transosseous, many people here on this webinar might agree that the transosseous repair is the gold standard. The giants of cuff repair have done this forever. But there's a lot of interesting things coming out in the modern times about biology, biomechanics, pain, revision considerations, and synergies with other hard fixators that are quite interesting and sort of updating this technique, I would say, for the modern era. This was written up. This is a hybrid technique that was written up in 2007 already with 400 or 500 newtons. And this is the first one I did arthroscopically, and I just recapitulated this technique. And again, your cuff repair methodology is an optimization of time, cost, fixation, usability, and what you can do in your hands and your system. But this was the first repair I did, just recapitulating what was already a strong construct in the literature, using basically biomechanical rationale, just as the TOE repair had done. Now, this is a slide on the right from the ESH meeting in 2018 or so. And in the green box, you can see this is Brian Cole's slide from Rush, showing that the transosseous equivalent with anchors has failure of 350 to 400 newtons. And this paper from Bernie Bach and Gus Mazzacca, who are smart researchers, called the multi-suture technique, shows that using all suture, you can actually double that, 856 newtons. So you won't have this shown to you by anchor companies, but they were ripping the surgical neck off the specimens with only suture. And so this is my version of this arthroscopically using hybrid techniques. And so I think we can achieve this now arthroscopically. The biomechanics of transosseous is different than anchor points. And we don't have this. Funakashi has shown with finite element analysis that there's a stress riser. And Seno has shown that that goes away with transosseous versus these pressure spikes that cause type 2 failure, essentially peak loading right into the area where the tendon can't heal. And this is why you get some of these re-tears, because it's exceeding, not matching the modulus. Scott Rodeo, one of the smartest researchers in the business, has shown, among others, that, and Shri Kumaran on this call has shown this as well, that suture number determines the strength. It's not the anchors. And so now that we can put a lot of suture in arthroscopically and easily, I think we're going to be able to address this concern. I would implore a lot of the thought leaders on this webinar to think about moving the paradigm from rows to fixation points per surface area and number of sutures per fixation point. This is what was not controlled for in the original studies, and it caused a lot of confusion. What's important is fixation points per surface area and number of sutures, not anchors. And so using these principles, basic principle thought, we devised this true transosseous hybrid technique. And so this is a triple row, if that matters, technique. You can see in the cartoon on the bottom left picture that has no anchor burden at the footprint. So it's only microfracturing, which is the only thing that's been shown to enhance healing actually biologically. So you have bone marrow vents, you have improved surface area for healing, and you have better revision considerations because you don't have inert material in your healing zone that you have to work around. It's triple row, but it's independent fixation. So you have knots fixing a transosseous X box, and then you have an independent anchor backing it up. So you're not relying on that lateral row anchor like you are, for instance, with a knotless transosseous equivalent. If you believe that there's problems with weak bone, you have bone augmentation. And if you're having trouble with tying knots or appropriate tension, that lateral row anchor allows you to tension the construct at the last step, retension it. And you have an improved cost per fixation point. So you see we're getting 5 fixation points here, but we could easily get 7 or even 9 if we wanted to expand this and put in more tunnels and just use 1 or 2 anchors as the surgeon wants. And this is also a self-reinforcing construct. So the more force that's imparted orthogonal or perpendicular to the construct, the more it compresses that surface area. So this is the same principles that we have just been discussing are important for cup repair are all now being applied at a reduced cost or a better cost ratio. This is what it looks like arthroscopically. You would think there's 4 or 5 anchors in there, and there's no anchors in that healing zone. This is all transosseous with 1 anchor down laterally. And this is my 14-month data of 143 patients. We had 4% re-tear. We had much less pain, about 2 VAS points less. And you can see this is SOS data showing the reduced pain when we changed to transosseous. We had a over 40-point increase in the ASES score. So excellent outcomes. And interestingly, 92% or 92 ASES scores, which matched perfectly Fabian Plaschel's study recently from Herbert Resch's data in 2019 JBJS. It was interesting. So very high ASES scores from this technique. So I'll take you through it here with a live first-person video. Here we're cleaning out the lateral gutter. Here's the TransOss device that I use through a small portal. We pop in through the subdeltoid fascia here. We've already made the medial tunnel, just like you would for an anchor. We use an awl to make a 2.9 millimeter tunnel here. We find that tunnel and place the transosseous device. It's quite stable. You see I can let go of it, and the assistant deploys it within about 20 seconds. So that's how long it takes to make a transosseous tunnel. So I think we've solved the time and usability problem there. And now we're going to bring the suture, the shuttling suture, out of the medial portal. This is now our shuttling suture, and we can shuttle tapes or sutures as the surgeon desires. I prefer the triplet. 3 sutures is the functional moiety of my repair constructs. It's a good balance. And here we clip the suture to the Coban in static mode inferiorly and in dynamic mode superiorly. So we let them slide superiorly and we don't let them slide inferiorly. And then we have topographic management. So what's happening on the outside of the patient is happening on the inside. And this is how we keep track of our sutures. Here is what the triplets look like from inside. You can see the monitor there. And then we're going to exclude the inferior sutures with the cannula. So this makes a suture management setup exactly like anchors. And now you're just dealing with the superior sutures. So it's very easy to pass your sutures in any manner you desire. And here we're going to link the tunnels. So we talked about linked constructs. So we're linking the constructs. Some surgeons have concerns about knot tying. So we're going to tie this outside the cannula. So it's a simple knot tying exercise outside the cannula here. Square knot backed up with alternating post half hitches. And we're simply going to tie those and pull them back in and manage those sutures from the top portal. Next, we'll tie simple sutures. I use an SMC knot with the knot low and lateral. We keep the knots off the top of the tendon, mostly for cosmesis, but that's a sliding locking knot. Here, interestingly, you can put the knot stack where you wish to make the compression optimized and to make the repair look nice and optimize compression. You can't do that with transosseous equivalent. And then we're going to secure the crossing sutures, again, by grasping the crossing sutures outside of the cannula, and we'll tie that knot again outside the cannula. Now, you could pull these in and go ahead and cut these sutures and you'd be done. That would be a transosseous X box. But what we're going to do is we're going to reduce a little dog ear here using the cannula to make it look perfect. And here we've left our tails long and we could be done here. You can see we're moving our repair side. It's got good shear stability, excellent footprint reconstruction. And we're going to take these tails that we've left, and this is going to give us a second chance to back up the construct independently with an anchor and also retension the construct in a knotless fashion. So we're going to bring this down in a self-reinforcing construct below the horizontal mattress limb. This is the triple row, and we're going to put that in as you would any standard anchor, but it's just one anchor, and there's no anchors in the healing zone. So you see it's quite solid, and here it is from laterally, and we do that in about 15 minutes or so. It's time equivalent. Independent studies have shown that. Lazarus and Black have shown that independently. So that's the repair. And these are the outcomes we get. We're getting excellent outcomes with these patients with much less pain. And we had a webinar last night about this. The bone pain, we think, could be coming from anchors and the bone marrow edema, which has been shown to last for about 6 months. And we simply just don't get that with transosseous repairs. And there's level 1 data out of Italy showing decreased pain. And here's an example of a cuff repair I did, and the radiologist read it as a normal cuff. So this is 6 months post-op, and the little white thing you're seeing there is a ferromagnetic artifact. So they can't even tell this cuff has been repaired. It's so natural in the healing. So I think that's very interesting. So there's a lot of interesting things to discuss.
Please time, Dr. Sanders, please time.
Okay, so we'll finish there. Thank you.